Inflammation of liver.
Inflammation of liver. Hepatitis is nothing but inflammation of liver. And what are the important symptoms of hepatitis? Yes. The onset of hepatitis is gradual or sometimes it is rapid.
Associated with fever, fatigue.
Yes, associated with fever, fatigue.
Abdominal pain.
Yes,
Tenderness associated with
Abdominal pain.
enlargement of
abdominal
liver.
pain, nausea, vomiting, then followed.
Malaise feeling.
Okay, so followed by jaundice, accompanied with dark urine and
Yes.
clay-colored stool.
Yellow skin.
Yes, yellow skin, that is, we call it as yellow pigmentation. Jaundice.
Tenderness.
Yes. What is the jaundice? Jaundice is a yellow pigmentation of skin and mucous membrane caused by excess of bile pigment. Okay. So in last lecture, we discussed about the type of jaundice. Okay. So what are the types of jaundice? Yes.
Pre-hepatic jaundice,
Yes.
hepatic jaundice, and post-hepatic jaundice.
Yes, yes. Pre-hepatic, hepatic, and post-hepatic. What are the causes of pre-hepatic jaundice?
It is hemolytic anemia, starvation, various drugs.
Yes. Yes, various drugs, starvation, sepsis,
And hemolytic anemia.
anemia. Yes. So intravascular or extravascular hemolysis. Okay. Is the cause of this pre-hepatic jaundice. Other causes are drugs, starvation, and sepsis. Okay. What are the causes of hepatic jaundice? Yes, what are the causes of hepatic jaundice? Yes.
Viral infection. Bacterial infection.
Yes. Yes.
Accumulation of bile.
Yes.
Alcoholic cirrhosis.
Yes. Yes. Yes.
Bacterial
So,
necrosis.
yes. So we call it as hepatocellular jaundice. And what are the causes of post-hepatic jaundice? Yes. What are
It is it may be gallstones, cholecystitis.
Yes. So obstruction. The main cause is
Obstructive jaundice.
obstruction because of stone or because of tumors. Okay. So in last lecture we discussed about the hepatitis, then viral hepatitis I think we discussed about. So today we are going to discuss the this particular type of hepatitis, that is hepatitis. There are 5 types of hepatitis. Hepatitis A, B, C, D and E. Okay. So today we are going to discuss about hepatitis A and hepatitis B. Okay. So hepatitis A virus. We are first talking about, going to talk about hepatitis A virus. Okay. So hepatitis A virus, it is a benign self-limited disease with an incubation period of 2 to 6 weeks. Okay. The incubation period of hepatitis A virus is, yes, it is 2 to 6 weeks is the incubation period of this particular virus. It is endemic with worldwide distribution. Okay. And it is also called as infective hepatitis. The disease caused by hepatitis A virus is called as infective hepatitis. Also, it is called as short incubation hepatitis. That is exactly opposite of hepatitis B. Okay. So that is 90 to 120 days, that is 3 to 4 months incubation period of this HBV virus, that is hepatitis B virus. It is called as long incubation hepatitis. hepatitis B virus, it is called, the disease caused by hepatitis B virus is called as long incubation hepatitis. Okay, and for this hepatitis A, we call it as short duration hepatitis. Okay, short incubation hepatitis. Okay, it does not cause chronic or carrier state and rarely cause fulminating hepatitis. It rarely causes fulminating hepatitis. We talked, I think, in last lecture about this fulminating hepatitis. Okay, so it also caused by hepatitis B and D also. Okay, so it turns into it turns very much severe due to necrosis. That's why we call it as fulminant hepatitis. The patient always develops in this fulminating hepatitis, that is confusion, stupor, and lastly the person acquires comatose condition. And when this condition, the patient goes through this condition, it is difficult to save the life of the patient. Okay, so it is called as fulminating hepatitis. Rarely causes fulminating hepatitis, but sometimes, again, according to the patient's habit, its immunity, resistant power. So everything is related with this. Whether the this disease it will get cured by itself or it will go into the fulminating stage. Okay. So fulminating, it rarely causes fulminating hepatitis. Now, hepatitis A virus is a small, non-enveloped, single standard RNA picorona virus. It is the family, we call it as a picorona virus that occupies its own genus, that is hepatovirus. Okay. So it acquires its own genus and we call it as hepatovirus. Okay. Ultrastructurally, this HAV is an icosahedral capsid that is 27 nanometer in diameter. It is sprayed by ingestion of contaminated water and food, and which is shared in the stool for 2 to 3 weeks before and 1 week after onset of jaundice. So the shredding of this particular virus from the stool is 2 to 3 weeks before and 1 week after the onset of jaundice. So it is RNA virus of picorona. It is RNA picorona virus which occupies its own genus hepatovirus. Okay, it is icosahedral capsid that is 27 nanometer in diameter, and it is sprayed by ingestion of contaminated food and water. Okay. Now this HAV, it occurs throughout the world and is endemic in the countries with substandard hygiene and sanitization. So the population there may have detectable anti-HAV by the age of that is young age. At young age, that particular population have detectable anti-HAV antibodies. So 10 years, at the age of 10 years. Okay. Clinically, this disease tends to be mild or asymptomatic. Okay. And which is rare, which is rare after childhood. This disease, it is rare after childhood. As the age increases, the percentage of this particular viral infection, that is hepatitis A virus, it goes on decreasing. The percentage of infection, it goes on decreasing. It is rare after childhood. Okay. Now this, it is small, very small virus, which is the other characteristics of this virus are, it is non-enveloped and single standard RNA picorona virus. Okay, that occupies its own genus hepatovirus. So the diameter of this virus, it is 27 nanometer. Okay, capsid. The capsid of this virus, it is, sorry, I think I have to, okay, now you can see clearly. Okay, so this is this RNA virus, that is hepatitis A virus. This is the capsid of virus, and the diameter of this capsid is 27 nanometer. Okay, it is RNA virus. You can see this RNA structure of this virus. This, it is sprayed by ingestion of contaminated water and food. Okay. The close personal contact with an infected person or fecal oral contamination during the infective period, it accounts for most of the cases, and which explains the outbreaks in the institutional settings such as schools or nurseries, and the this waterborne epidemics in the places where the people live in very much crowded area, overcrowded area, or in living in the unsanitary conditions. Okay. HIV, it is not shared in any significant quantities in the other body evacuations, like we could not find this virus in the other body evacuations like saliva, urine or semen. Now, yes, any query? Yes, any query? Please mute your this speaker. Now, now about the serological diagnosis of this disease. Okay, before going towards diagnose, we will look for the other characteristics of this disease and the virus. So this virus could not be isolated by culture. Please mute yourself. Who kept his this mic? Mute yourself. This virus could not be isolated by culture. Okay. And biochemically, this HIV is a RNA virus resembling closely like a enteroviruses, that is picornaviruses. We call it as picornaviruses. Now, pathogenesis of this particular disease, that is hepatitis A infection. The route of infection, it is of course orophycal route, orophycal route. There are the stages of this particular disease. Clinically, there are 3 stages. The first stage is pre-icteric phase. Like in this pre-icteric phase, what is icterus? That is yellowishness of conjunctiva. So pre-icteric phase, it is associated with malaise feeling, nausea and vomiting. We call it as phase 1. Phase 1 infection, that is pre-icteric phase, associated with malaise, little feverish sensation, nausea and vomiting. Second phase is icterus phase. It is associated with jaundice, and it is also called as prodromal stage or icteric phase. It is also called as prodromal stage. The third stage is convalescent stage, that is the stage of recovery. Convalescent stage is the stage for recovery. Okay. Now, these fecal infectivities are maximum in the prodromal stage. We can get this virus from the fecal route or excavation of this virus from the fecal route. It is maximum in the prodromal stage. And the viremia, it also begins in the prodromal stage, but it is transient. The viremia of this prodromal stage is very much transient. Okay. The transmission occurs by fecal-oral route, and it is always favored by poor personal hygiene, overcrowding, close contacts, which again there is increased incidence. It is mainly seen in the homosexual males. Okay. Now the source of infection, like water, contaminated water, milk, food, shellfish or prawns. Okay. So in developed countries, the sporadic infections may be contracted by consumption of raw or steamed shellfish, that is oyster, mussels and clams, okay, which concentrate the virus from seawater contaminated with the human sewage. So whenever the seawater get contaminated with the human sewage, this infections get rises. Okay. So the infected workers in food industry may also be the source of outbreaks of this particular epidemics. Okay. Now, because of this HAV viremia, it is transient. The blood-borne transmission of HAV occurs very rarely. Okay. Therefore, the donated blood is not specifically screened for this particular virus, HAV virus. Okay. So the blood-borne transmission, it is very, very rare in this particular, about this particular viral infection. Okay. That is due to HAV, hepatitis A virus. This viremia is very much transient. Okay. Now, the serological diagnosis, or we can say immunological markers of HAV. It is very, very important part. What are the markers of HAV? It is the question always asked for 2 marks or 5 marks also. Okay. So the specific antibody against HAV of immunoglobulin, that is IgM, specific immunoglobulin, which appears first after the infection of HAV virus, is immunoglobulin M. So this immunoglobulin IgM type appears in the blood at the onset of the symptoms, constituting a reliable marker for the acute infection. Okay. So the fecal shedding of the virus ends as the IgM titer rises. So this IgM titer, that is IgM antibody, it rises fast during the acute illness and disappears in the few months. So the during convalescent phase, the titer of IgM start rising with this particular titer, it persists for lifetime and converts the immunity to HAV, lifetime immunity for HAV infection. Okay. So this IgM, what is the important? That is IgM response usually begins to decline in a few months and it is followed by appearance of IgG, that is anti-HAV. Okay. And it later persists for few more years, perhaps for the lifetime, providing protective immunity against the reinfection by all the types or all the strains of HAV. Okay. So hence HAV vaccine is effective. Okay. So this is the serological diagnosis of this or immunological marker of HAV virus. Okay. So the first specific antibodies which react against HAV, that is immunoglobulin M, IgM type. It appears in the blood at the onset of the disease, that is the disease symptoms, and it constitutes a reliable marker for acute infection. Okay. The fecal shredding of virus ends as the IgM titer rises. It is very important. It is inversely proportional. When fecal shedding of the virus ends, the IgM titer rises. Okay. And this IgM response usually begins to decline in few months and it is followed by appearance of this IgG class of immunoglobulin. Okay, so this IgG class of immunoglobulin, IgG anti-HAV, that it persists, this titer persists for the lifetime, and it provides the protective immunity against the reinfection. So lifetime immunity can be acquired with this particular strain. So IgM is an indicator of recovery of the disease, or second indicator, a recent infection, third indicator, a past infection, okay, or after the infection, a post infection phase. So recovery from the disease, it is an indicator of recovery of the disease. It is an indicator of recent infection, and it is an indicator of past infection. Okay, so IgM class of immunoglobulin, which provides the lifetime IgG, with the help of IgG, it provides lifetime immunity for this particular HAV infection. Okay, so this is all about of hepatitis A virus. Okay, so it is this is the structure of this. It is a RNA virus. This is the structure of this particular virus. Okay, then we will go towards hepatitis B. Very, very important. Hepatitis B virus. Now the clinical stages of this hepatitis B. There are 3 stages of this hepatitis B. Okay, carrier state of the virus, then acute hepatitis, and third, chronic persistent hepatitis. Okay, so this hepatitis B can produce acute hepatitis, chronic hepatitis, which may evolve to cirrhosis. This chronic hepatitis, it may evolve to cirrhosis also. Third is fulminating hepatitis with massive liver necrosis. Okay, here necrosis is very much massive, and commonly this fulminating hepatitis caused by this hepatitis B, and rarely with hepatitis A. Okay, it also plays important role in development of hepatocellular carcinoma. Okay, so hepatocellular carcinoma is again a complication of this after this hepatitis B infection. Okay, so it is a global disease, hepatitis B. It has prolonged incubation period, that is 4 to 26 weeks. It remains in the blood up to and during the active episodes of acute and chronic hepatitis. Okay. Now it presents in all physiologically or pathological body fluids, but the exception is of stool. Okay. So we can see this particular virus in the body fluids, that is all body fluids, okay, that is sweat, saliva, or semen, urine, as excreta, then in the plasma, okay, all body fluid, either it is pathological or physiological. Pathological is nothing but the inflammatory fluid, okay, so but the exception is the stool. Now this is very much vigorous virus, or it is a very hardy virus and can withstand extremes of temperature and humidity. Okay, so it is very much fulminating virus. It causes fulminating hepatitis, fulminating infections, and also it produces the complications like hepatocellular carcinoma, then chronic hepatitis, which may evolve to the cirrhosis also. It gives massive liver necrosis. Okay, so very vigorous and very fulminating type of virus this is. Okay, this is the structure of this hepatitis B virus. Okay. Now, Here, for this particular infections, for hepatitis B virus, the blood and body fluids, they are the primary vehicles of transmission. The virus may also be sprayed the other way, that is sprayed by contact with the body secretions such as semen, saliva, sweat, tears, then breast milk, and pathological effusions, that is inflammatory fluid. Okay. Then transfusions, blood products, then dialysis, then what other else, that is needle stick accidents, then which is very much common in the healthcare workers. Okay. Then intravenous drug abusers, homosexual activity, they constitute the primary risk categories for this HBV infections. Okay. So in 1/3 of the patients, the source of infection is unknown. And the endemic areas or endemic regions like Africa and South Asia, the spread from an infected mother to neonate during birth. That is, we call it as vertical transmission. It is very much common with this endemic areas. It is very much common. These neonatal infections often lead to the carrier state of or for lifetime. They indicates, they gives rise to carrier state. So those neonates which got this particular viruses, neonatal infections, that causes that to that neonates, it leads to carrier state for the life. Okay. So here you can see the structure of this virus. A nucleocapsid, that is core protein. It is nothing but a family of Hepadinaviridae family, that is of DNA virus. It is nothing but DNA virus. It has capsid. Okay. And this there is surface antigen is present, that we call it as HBS antigen, also known as Australia antigen. Then core antigen is present, E antigen. Then it is a, this is the DNA polymerase. Okay. And we call it as a reverse transcriptase. Okay. The other figure of hepatitis B virus, this is the DNA, double stranded DNA. It is made up of the there is a lipid core, it is present with the virus, and the core, it is inside the virus. There is a core antigen. Then the surface antigen, it is present here. So large surface proteins are also present with this on the surface, this capsid. Okay. It is made up of the lipid bilayer membrane. Okay. This particular covering, it is made up of lipid bilayer covering. So a nucleocapsid, that is core protein, HBCAG, that is hepatitis B core antigen, and a longer polypeptide transcript with a pre-core and core region. Pre-core, this is pre-core region, and this is core region. Okay. So the pre-core region directs to HBeAg polypeptide towards the secretion into the blood, whereas this, see, there is HBe in this, this is HBe. E antigen, we call it as E antigen. Okay, the pre-core region directs to HBeAg polypeptide towards the secretion into the blood, whereas this HBcAg core antigen, we call it as core antigen polypeptide, it towards the secretion into the it remains in the this particular HBcAg, that is the core antigen. This remains in the hepatocyte for the assembly of complete virion. It always remain in the hepatocyte, HBcAg, core antigen. Okay. And this E antigen, that is hepatitis B E antigen. Okay. So it is nothing but the envelope antigen. E is nothing but the envelope antigen. It acts as an envelope which remains in the pre-core region. E antigen. Okay, and it is this precore, this region, it directs the HBeAg polypeptide towards the secretion into the blood, and this HBcAg, that is core antigen, it remains in the hepatocyte to complete the virion. Okay. Now the envelope glycoprotein, that is HBsAg, this is the surface antigen. Okay, HBsAg, the surface antigen. Here the infected hepatocytes, they are capable of synthesizing and secreting massive quantities of non-infective surface protein. This is the surface antigens. It is in the form of protein. Okay. This HBsAg appears in the cell and the serum as sphere and tubules, approximately 22 nanometer in diameter. So we'll see more things about the structure of this hepatitis B virus. Okay. So the virus core of HBV, it is synthesized within the nuclei of hepatocyte. This virus core of the HBV is synthesized within the nuclei of hepatocytes. The core contains, this core of this HBV virus, it contains that is hepatitis B core antigen. We call it as hepatitis B core antigen. Then double standard DNA. This is double standard DNA. DNA polymerase. These are the molecules. They are known as DNA polymerase. And E antigen, it is also associated with core, that is envelope antigen, E antigen. Okay, this is E antigen. So this is all about of core. Okay, now both of this core, that is envelope and the surface, sorry, both envelope, this E antigen, that is envelope antigen, and surface antigens, they are synthesized in the cytoplasm of liver parenchymal cells. Okay. The viral core, this viral core material, this is the core material. It is produced in excess in the cytoplasm of hepatocytes in the form of spherules or tubules of 22 nanometer in diameter and few hundred nanometer in the length. Now, these spherules and tubules, it passes the core antigen, okay, that is HBcAg, and also the surface antigen only. It possesses the surface antigen and core antigen. These spherules and tubules, they possesses the surface antigen, that is HBsAg, and core antigen, that is this HBcAg. Okay. Now these spherules and tubules, they are the naked core particles and usually do not appear in the blood. They are found in the cytoplasm of the hepatocytes. Okay. Now, this is about the core part of this particular hepatitis B virus. This is all about of core part of hepatitis B virus. Okay. Now, the surface antigen that we will talk within few minutes. Just I'm going to call back this meeting because there is the time is ending. So I'm going to stop the lecture and please connect within few minutes. Okay. So we can complete this hepatitis B virus within few minutes today only. Okay.